Hi, in this lecture we are going to look at some clinical issues that affect your blood. We will look at some clinical issues of the red blood cells and the white blood cells and the platelets, and then we'll look a little bit at plasma and whole blood. So I know you've heard of anemia before. So what is anemia? Well, anemia happens, it basically is a generic word for the blood just can't transport as much oxygen. So if we look at our normal blood, anemic blood often is less red. Usually it has too few of the red blood cells, or it doesn't have as much hemoglobin. So typically your skin is more pale because the redness of the skin is due to the hemoglobin. And so if you don't have the cells or you don't have the hemoglobin, you're more pale. You can see the different signs of anemia. If you don't have the oxygen, you might be dizzy, you can be lightheaded, you can be confused. Those neurons need to have the oxygen. Your heart is probably going to have to try to pump harder, try to get the oxygen to the blood. You might have heart palpitations, your heart might be a little faster. With less circulation, your extremities might be colder, right? You might have cold hands, cold feet. Your blood pressure might be lower because you're basically trying to pump the blood through and your blood is kind of thinner. You might have pallor, light colored skin. And then as far as the lungs are going to be affected because you're not able to transport that oxygen as well. So when we look at anemia, again, we'll look at different causes of the anemia. So the first thing we're going to look at is the more common is maybe you don't have enough red blood cells. Now we talked about this already. If we're looking at our hematocrit, when we look at hematocrit, the percent of red blood cells in a blood sample, we know that if it's too low, we don't have enough red cells. And there's many causes of this, and there's ways to diagnose this. So you run a patient's hematocrit, it's too low. Well, maybe it's too low because they're bleeding, right? Maybe there's an internal bleed. Well, an external bleed is pretty obvious, right? They cut their finger off or they're hemorrhaging. You have some sort of trauma. Internal bleeds can be a little harder. Maybe they're post-surgical. So you're on an OR floor and you're on a med-surg floor and you're watching this to see if there's any internal bleeding post-surgical. Maybe they have a GI bleed that's happening or internal bleeding. So it could be low due to bleeding. We call this hemorrhagic anemia. Maybe they're not bleeding, but maybe the red cells are being lysed. So they're being destroyed in circulation, hemolytic, see lytic. So something's attacking them. This could be infections. Different bacteria can do this. The immune system can attack. Maybe there's a blood transfusion that's wrong. Different medications or drugs can do this. So now they're being lysed prematurely. Well, remember, if they're being lysed prematurely, those products, when those red cells are popped and burst, they have to be lost in the kidneys. So when this happens, you're going to do a urinalysis test and you're going to see some hemoglobin in the urine. So you'll have a hemoglobinuria, and that would be a sign of hemolytic anemia. Maybe you're not bleeding. They're not being attacked, but you're not making them. So now we have aplastic anemia. Something's going on and they're not being formed. So they're not being made in the bone marrow. So something's destroying the bone marrow. So this could be genetic. Some medications do this. Some anti-cancer drugs. Chemotherapy does this when it attacks the bone marrow. Some antibiotics can do this. Some anti-seizure meds. Radiation is classic for this. Radiation poisoning, chemotherapy can also do this. Even some viral infections. Now you might remember that precursor cell to the red blood cell was called the reticulocyte. And so this is the cell that's in the bone marrow. And the reticulocyte, the reticulocyte count gives us some information about the production of red blood cells. Now let's think about this for a minute. What would happen to your reticulocyte count for some of these situations up here? So if I'm bleeding, right, or I have hemolytic anemia, what do you think will happen to my reticulocyte count in response? Well, if you think about that for a minute, it'd probably go up, right? Because if I don't have enough red blood cells, my bone marrow is going to reply by trying to make more. That's the goal, right? If I have aplastic anemia, what's going on my reticulocyte count? Well, ideally, I would want it to go up, but it can't because the reticulocyte count's in the bone marrow. So aplastic anemia is characterized not only by a low hematocrit, but also a low reticulocyte count. Also note the platelets and the white cells are also reduced, because remember, all of these cells are made in that red bone marrow. So all of those would be reduced. Now, pernicious anemia is different. This is when you don't have vitamin B12. Now, there's a lot of food you can eat to make sure you have vitamin B12. So it would be abnormal to be deficient in B12. In fact, your stomach makes something called intrinsic factor. So it's made by the stomach, and B12 is pretty big. Normally you get it by an injection because it's so big. It needs to bind to intrinsic factor to be absorbed. So if people have gastric bypass surgery, sometimes they don't make enough intrinsic factor and they can get pernicious anemia, so they go on B12 injections. So normally it's not an issue. With pernicious anemia, often you might have like a tingling sensation or numbness in your hands and your feet, and then you'll be tired, and then for some reason it causes this weird, like really smooth, bright red tongue. So the treatment would be B12 injections, and make sure you get enough B12 in your diet. So these are all causes of anemia if you don't have enough red blood cells. But you can also be anemic if there's trouble with your hemoglobin. So let's throw my head right there in the middle. Now, one of the most common issues with hemoglobin is going to be iron deficiency anemia. So hemoglobin, remember, binds to iron, and it's the iron that binds to the oxygen. So in females in particular, when you lose iron, when you bleed, iron leaves your body. We normally hold on to it and recycle it all the time. In fact, some people have too high iron levels, and then their treatment is to donate blood and get rid of it, because we normally hold on to it. But women, if you menstruate, you're losing iron every month, and so you're more prone to iron deficiency anemia. Now, if you have frequent nosebleeds or GI bleeds or had major surgery, then you are also prone to iron deficiency anemia. And you can see some of the signs and symptoms typical. Fatigue and when you don't have enough iron, and anemia, typical signs and symptoms. And the treatment is to get iron. So you want to make sure you eat your iron-rich foods. Now, another form of anemia with hemoglobin is going to be your sickle cell anemia. So sickle cell anemia is a genetic disease, so it's inherited, and it's a one base mutation that causes the hemoglobin to change its shape. So the red blood cell, instead of being nice and round, is going to be this like sickle cell. And what happens is it can scrape up the inside of a capillary. And when these red blood cells go into this shape, it's called a sickle cell crisis. So if you have sickle cell anemia, and if you took Bio 119, you might remember there's different forms of the disease. But when the red blood cells go into this shape, when a lot of them go into the shape, we call it a sickle cell crisis, and it can be pretty bad. It can clog up the vessels. It's very, very painful when it occurs. And so typically, the treatment, they usually do a blood transfusion for that, because it can damage the retina of the eyes. It can damage the kidney. It can cause a lot of problems. And they just did gene therapy for this. So I put this link in here for you if you want to take a peek at it. So, recently for this lecture, depending on when you're watching this, but December 8th, 2023, they have a couple gene therapies for sickle cell, and you can go check it out. It's kind of interesting. The idea with gene therapy is that you actually cure it. So there's two. One uses this thing called CRISPR, which hopefully you learned about in Bio 119. Pretty cool. I think one is $2 million, and one I think was $3.3 million. But it cures you. You don't have the disease anymore. Don't think it's covered by insurance, though. Now, the opposite of the anemia is the polycythemia. So anemia is when your hematocrit's too low, and then again, we have what's called hypoxia, right? We are unable to really get oxygen to our tissues, so we have that fatigue and we don't feel well, headaches. Polycythemia is when there's too many red blood cells, and a lot of times it can happen when we're dehydrated because we just have less water in our plasma, so that could happen. It's very, you're not going to see it too often. There is a rare cancer that can cause it, probably not going to see that. It could happen if you're at really, really high altitude for a long time, but you're probably most likely going to see it with blood doping. So blood doping is when individuals either save their blood and put it back into them, or they're going to take EPO, because they're trying to boost their hematocrit to increase their aerobic performance so that they can do better at different events. Like cyclists are famous for this. Remember though that when you increase your hematocrit, your blood gets really thick, more like syrup, and now it's going through those vessels really slow, it's thicker, it's gonna be a lot harder to get blood to the smaller vessels, and unfortunately it's often fatal. So as you can see, I'm having some video issues, so I'm just going to finish up this lecture off camera. So leukemia we will talk more about when we get to the next unit and we look at the lymphatic and immune system, because it covers both systems. So what is leukemia? Leukemia is actually cancer that originates in the bone marrow. It's cancer of the white blood cells. Remember that leukemia is uncontrolled mitosis, and the stem cells that are in this red bone marrow are going to have a problem with mitosis where they're going to replicate and produce abnormal white blood cells. So there'll be too many of these, and these abnormal white blood cells basically crowd out the red blood cells, the erythrocytes and the platelets, and so you often have a decrease in your red cell count as well as your platelets, which can cause problems with hypoxia and problems with bleeding. When we look at leukemias, these white blood cells often migrate to other areas of the body, to other lymph organs, which is why it also causes lymphoma. So typical signs and symptoms of leukemias, you've probably heard of some of these before, but we're going to have often weight loss and fever with frequent infections. These white blood cells are abnormal, they don't do their job, and then you get a lot of swelling in the other lymph organs. And again, we'll talk more about the lymphomas and leukemias and the treatment in our next unit. I know you've heard of infectious mononucleosis. It's now known that it's caused by a virus, the Epstein-Barr virus. And this is a virus, so it usually just has to run its course, and it usually lasts a few weeks. Typically causes flu-like symptoms. If you've had it, it's not pleasant. Usually extreme fatigue, sore throat, fever, you have your swollen nodes. It can cause your spleen to enlarge, which is why they say no contact sports with mono. The spleen is on the left side. It gets a little bit of protection from the ribs, but anytime you have a chronic infection, those lymphocytes and monocytes like to go hang out in the spleen. And this is another thing we'll talk about when we look at the lymphatic system. Some people get a rash with mono, especially if they go on amoxicillin. You can do blood work to test for the presence of mono, but again, it usually runs its course. It's called mononucleosis. The monocyte count typically goes up as well as the lymphocyte count. Now we're going to talk about thromboembolic conditions, and this is when you form a clot when you're not supposed to. So a thrombus is a blood clot, but the concern is if you form a clot when you don't need one. Now it's critical that this happens anytime you damage a blood vessel and you get a bleed because you need to plug up that hole. However, what if you form a clot when it's not supposed to be there? Well, now you have something obstructing blood flow, so you're going to reduce blood flow to an area past that blood clot. So a thrombus can block the vessel and reduce blood flow, whereas an embolism is when you have a piece of a thrombus break free and now you have a traveling blood clot. And the concern with that is that it's going to eventually get to a smaller vessel, and now it's going to clog that vessel. So you might hear of a coronary thrombosis. If you hear of a coronary thrombosis, this would be a blood clot that's in a coronary vessel. If it's, well, let me spell this right. If it's in a coronary artery, it's often going to cause a heart attack. They can be in an artery or a vein. You might hear of a DVT or a deep vein thrombosis. This is one that's in a vein. We'll talk more about these when we look at blood vessels as well, but you can see how they obstruct blood flow, and then if a piece breaks off, you've heard maybe of a pulmonary embolism. So what causes these things? Well, there's a lot of factors. We know genetics. We know that a lot of those procoagulants and anticoagulants are proteins, so they're encoded by your DNA, so they tend to run in families. We know that if you have too many procoagulants, you're more likely to form these clots. Or if you don't have the anticoagulants, maybe you have a protein C deficiency. Remember, protein C is going to prevent abnormal clots from forming. Stationary or stagnant blood flow. Maybe you're on a long flight and you're just sitting in your seat for hours. We know that when you wake up in the morning, your blood is more stagnant. So anytime blood is not moving, it tends to become thicker and have an increased risk of clotting. This is one reason why exercise is helpful at preventing this, because it keeps your blood flowing. When you have an injury, any damage, remember, to this lining, this endothelium, can trigger the process of forming a blood clot. Certain birth control pills, we know that estrogen is something that helps with keeping our HDL levels. So we have HDL, which is our good cholesterol, and we have LDL, which is our, quote, bad cholesterol. Well, HDL keeps our arteries cleaner, so it helps prevent these like plaques from forming. And we know that estrogen is really helpful at keeping our HDL levels high. Well, some birth controls actually lower estrogen and they block this HDL. So when we look at cholesterol, we're really worried more at the LDL, the bad one, because that can help form these clots. Smoking increases the risk of clots, without a doubt. And so these are things that can do this. So you can decrease your risk of having these by changing some of your lifestyle. And obviously we'll get to the medications in a minute. So exercise is important. It does help keep blood circulating and help keep platelets less sticky, because those platelets tend to stick together anytime you have this slow flowing blood occurring. And remember, if they're going to stick, they're more likely to form that clot. We know diet, there's different things here. I put some pictures here. You'll recognize maybe your garlic and some cinnamon and maybe your cayenne peppers, but there's different food items that we can eat, things we can add to our diet. Turmeric, that definitely has been shown to decrease the stickiness of our platelets. So what we eat, also, eating a high fiber diet to help with the cholesterol levels and maintaining normal blood pressure and weight. Now, what if you are prone to these clots? Well, then you probably need to consider some form of pharmaceutical treatment. So we have what are called blood thinners. Blood thinners are antithrombotic medications, and there's really two general routes that they fall in. They're either anticoagulants or antiplatelets. So they're just two mechanisms. So the mechanism is, how does the drug work? The end result is to decrease the chance of forming a clot. So an anticoagulant literally prevents the formation of the clot. When we went through the coagulation pathway, we talked about these procoagulants, and we talked about the formation of the temporary clot, and we talked about the formation of that final clot, that stable clot. So an anticoagulant will interfere somewhere in that pathway, and you can see some examples. Whereas an antiplatelet doesn't interfere with that last step, that coagulation cascade, but it does keep those platelets from sticking together. So it interferes more with the platelet plug, which again, it interferes with that temporary plug. So they both have a similar effect. They're used, for slightly different reasons. So if we look at these, you don't have to memorize the name of the drug, but I do want you to know a little bit about the mechanism, which I just went over. So an anticoagulant will block some form of clotting factor. Here's the overview. We already talked about the intrinsic, the extrinsic, and the common pathway. So these are used a lot for, I mentioned the DVT, deep vein thrombosis. So this is a blood clot in a vein, a PE, a pulmonary embolism, or a disease that might cause them. And so the more common ones are heparin, which I know you've heard of that. Heparin basically produces antithrombin. And antithrombin is just what it sounds like. It inactivates thrombin. Remember, thrombin was part of that coagulation cascade. So we can block thrombin as one of our, so if we block the thrombin, then we will decrease our clotting. We have factors that work against vitamin K. Remember, vitamin K was necessary to make several of these clotting factors. So this is how Coumadin works, Coumadin or warfarin. Now with this one, you have to get blood work taken quite a bit because it basically blocks vitamin K, so you don't make the clotting factors. So your patient has to get checked fairly frequently. The good thing about it though is that if there's too much Coumadin, you don't want your patient to bleed too much, you can just give vitamin K and correct it pretty quickly. But because it's a little more guesswork, it's not as precise, you have to have labs drawn frequently. The new ones, these are the direct acting oral anticoagulants. They work quicker, but they have shorter acting effects. There's no direct antidote, and again, you don't have to memorize their names, but they come down and block factor 10A. So when we're looking at an anticoagulant, they're doing something in this coagulation pathway to block the actual clotting, that prevent formation of that platelet, that coagulation, right? When we had that stable fibrin plug to occur, and that's how these meds are going to work. Now, if we look at the antiplatelet, aspirin is the cheapest one and just as effective as Plavix, which is the medication form. These, just what they sound like, they're going to prevent the platelets from forming that platelet plug. This is Xarelto. This is one of your anticoagulants over here, one of your direct acting ones, and this is your antiplatelet. So they're very, very similar. They just have a slightly different mechanism. Now, I did throw the NSAIDs in here only because there's some evidence that in certain people, taking your NSAIDs can actually increase your risk of having a heart attack. And it's select people. And what I want you to understand is that when you take the NSAIDs, so we're looking at your Motrin, your naproxen, and they have slightly different mechanisms. But what they do is they inhibit enzymes. So there's something called arachidonic acid, and the enzymes, they're cyclooxygenase. So we just say COX-1 and COX-2. So the NSAID is a drug that prevents that enzyme from working. Well, what that enzyme does is it converts this big thing, arachidonic acid, into thromboxane A2, which you've seen in our lecture so far, prostaglandins, and prostacyclin. And these words should look familiar to you. So the NSAID inhibits these. And so there's different evidence out there, but from what I can gather is the biggest effect is when they inhibit prostacyclin. Now, prostacyclin, remember, is helpful in that it inhibits the platelets. So if you inhibit prostacyclin, now your platelets are more likely to clump. So it appears that in certain people, when they take the NSAIDs, their platelets become more sticky and more likely to form that clump, which can increase the risk of forming the clot, hence a heart attack. Also, in certain individuals, these NSAIDs can directly affect the platelets and also the bleeding, and they can increase bleeds. So in some people, their stomach lining actually causes more bleeding, and that's why it can really upset their stomachs more. And this tends to be more individual based, and I'm not sure if they figured out or tweezed out why that happens in certain individuals more than others. So I just want to mention that briefly. You do not have to memorize this pathway of arachidonic acid. I just want you to be aware of that. Now, what if you have a clot? So then our last group here is when we're looking at these meds is we have what are called thromboembolytics, or these are technically called the clot busters. So these actually break up a blood clot. And what they do is they mimic what's naturally occurring in our body is our plasmin. So we talked about the fact that we had that TPA, and that TPA is going to activate basically plasminogen into plasmin, and then plasmin is going to break down this clot. All that fibrin is going to start to slowly break it down and get rid of it. So there's meds, you don't have to memorize the medication name, but they basically mimic TPA. And then there's something made by bacteria called, it mimics streptokinase, which is an enzyme from the strep bacteria. And so this is another medication that can be given because what they do is they dissolve the blood clot. So if a patient has a clot, they can try to give the TPA medication, the clot buster, into that clot and dissolve it to restore blood flow. So if there's a stroke or a heart attack, this is a picture of an ischemic stroke. There's two types of strokes. There's ischemic, which is from a clot, and then there's hemorrhagic, which is from a bleed. Now, you wouldn't give this in a hemorrhagic stroke or your patient would bleed to death, but you would give this in an ischemic stroke, or if your patient has a heart attack. And in fact, if a heart attack is suspected, a lot of times you'll probably want to just take some aspirin to try to help prevent those platelets from sticking together. So these are the clot busters and why they would be used. Now, I want to wrap up with two quick things. You've probably heard of the convalescent plasma therapy through the whole COVID pandemic. So convalescent is when someone recovers from a disease. So in this example, it can be any disease, by the way. It's been done with Ebola and other illnesses. So you have a virus. The patient gets infected with it. In this example, COVID-19. The patient recovers. When the patient recovers, they have antibodies against that virus in their plasma. So now if another patient becomes infected, you can take the patient's blood, patient 1 who has the antibodies, you can spin that blood down and get their antibody-rich plasma, inject that into the infected plasma, and save their life. And this was done in the early stages of COVID, and it was a treatment. So you're basically doing an antibody transfer to help boost another person's immune system, and that's called convalescent plasma therapy. And then lastly, you've heard of platelet-rich plasma therapy. We talked about this in AMP1. And so because the platelets have actually growth factors as well that they know, is you take a patient's blood, you spin it down, and you get the plasma with the platelet piece in it. Remember, you have that little, like, there's a buffy coat area, the platelet rich section. And what they found is those growth factors stimulate mitosis. So they started doing this for ligaments and tendons and joints. They've actually been doing it to regrow hair. And so these are some of the common areas of the body where they've had a lot of success and causing recovery from, ligaments, tendons don't really heal that fast. Cartilage, a lot of times in surgeries, they'll go in and they'll try to scrape up the bone and get some stem cells in there. And now they can do this injection with this platelet therapy. And then last is just a real quick comment regarding synthetic blood. And this is something they've been trying to make. We know that we have shortages in blood all the time. If you donate blood, I give you extra credit. It's just 3 points. It's just a good thing to do. You just show me your donation slip. So they've worked on trying to make it from stem cells. It's very difficult to do. Just know that it's a process they're working on. And then I just read about a research program at University of Maryland where they're actually trying to make a blood product that's basically freeze dried. So when you get those ice packs that you bang against your leg and you twist them and they turn cold, they're trying to make a blood product like this that you would just twist and it would turn instantly into blood. So I put this link in here and you can look it up yourself, but it's kind of a cool idea that they're doing right down the street from us, where they're trying to make this artificial blood, because unfortunately a lot of people die, whether they're on the battlefield or in an accident, before they can get to the hospital. And there's a little video that I'll post for you if you want to watch it. But it's this really cool idea where they're bringing experts from a variety of different fields together to try to create this artificial blood. And one of the funniest things I've read is that the main person is Doctor, who's going to be behind this. So pretty cool. So that wraps up our lecture on the clinical aspects of blood.